Sumit.
A very good morning to all of you. The topic which was given to me by Devashish was this: have tryptans made a difference in migraine management in India? And I was ignorant enough to not look at the final program. And when I came at around 7 in the evening for the debate, I saw that the topic is a different one. So after that gala dinner and those exemplary extra academic activity, I was in no way in a position to change the topic. It was difficult to only get up in the morning, so forget about changing the topic. So I'm continuing with this. Have tryptans made a difference in migraine management in India? Because
it is not going to make much difference.
Yeah, one doesn't make much difference, and second is this looks more interesting to me. So what impacts the usage of a drug in practice depends upon its efficacy. So this I will cover by giving you evidence for the use of tryptans in migraine, whether these drugs are tolerable, what are the side effects. I'll be telling you about the side effect profile. What is the duration of effect? So that would be highlighted by the mechanism of action and pharmacokinetics. What is the frequency of administration of a drug? What is the route of administration? So we'll be discussing about the available preparations and what is the cost involved. So I will not address the epidemiology because nobody remembers. I will not present the detailed pathophysiology because even I don't know, actually nobody does. When there are too many theories, probably none of them are correct. So I'll be touching on the relevant aspects of pathophysiology, the relevant details of acute treatment. I'll discuss tryptans as a group and their place in headache management in India. So why the people are dissatisfied with their present acute headache medicines is because they feel that the pain relief takes too long. It doesn't relieve all of the pain. It doesn't always work. The headache comes back after the effect of the drug has gone, or there are too many side effects. And there is a phenomenon of rebound headache, and it increases, it basically increases the chances of a medication overuse headache. Because every rebound requires more painkillers, and these patients they tend to develop a medication overuse headache frequently. So whenever we prescribe acute medications, we have to understand what are the chances of rebound, and also what are the chances by prescribing a particular drug of this patient to land into medication overuse headache. Many people would demand a particular treatment, like this lady who presented to us. My migraine goes only with that P drug, that P pethidine. It works when I take it IV only, and only when I take the full ampule. I have to get Benadryl because I can get really itchy after taking pethidine, and I'm also very nauseated, so I'm allergic to all the anti-nausea medications except IV phenargin. So this was a patient who is dependent on opiates. So medication overuse headache can lead into this type of a situation, and we should not give in to the requirement of the patients. So what are the goals of acute migraine treatment? We have to give medicines which are effectively going to take care of the headache rapidly and consistently without recurrence, which we would call as a pain-free state, restore the patient's ability to function, minimize the use of rescue and backup medications, optimize self-care, and reduce resource utilization and minimize the side effects apart from being cost-effective. So if there are too many medications which are available, then according to burst rules, probably none of them are working too well. And then we have these non-pharmacological interventions where this lady says, I need to have my mind off something, and a crocodile is right in her toilet. And then this prescription which has been actually prescribed by people where alcohol is permitted, and they have even told about what type of alcohol can be taken for the treatment of an acute attack of migraine. So abortive treatments depend upon educating these migraine sufferers, using migraine-specific agents in severe diseases or in special situations. Non-oral routes can be used for patients who have significant nausea, and then yes, we have to be aware of the medication overuse headache and rebound headaches. So there are various classes of drugs which are available to us. These are the over-the-counter simple analgesics, non-steroidal anti-inflammatory drugs and COX-2 inhibitors, anti-nausea medications, tryptans, ergots, and opiates. So there are two ways of managing these patients for an acute attack. whether we give them a stepwise approach in which we start with a single analgesic and add on a second liner and or a triptan later. The second is a stratified approach in which we see what is the type, what is the severity of the pain, and then treat these patients accordingly. So milder patients would take only a COX inhibitor or a non-steroidal inflammatory drug. A severe patient might require a triptan, an ergot, or something of that sort, depending upon the classification of one particular headache type into mild, moderate, or severe. So, with reference to triptans, there is something which needs to be discussed about the pathophysiology. Migraine is actually a syndrome in which the headache in the migraine is the final common output. The cortical spreading depression is probably the reason behind the aura, and it is actually the activation of the trigeminal system due to vasodilatation, secondary to release to these chemical mediators of inflammation which causes the pain because of the sterile neurovascular inflammation. And the central sensitization is basically a decreased brain threshold which is responsible for the allodynia, which is very commonly seen in these patients. Now, 5-hydroxytryptamine agonists or triptans are a group of drugs which act on these receptors, and there are two specific types, 1B and 1D. So 1B receptors are in the walls of the blood vessels, and their stimulation leads to constriction of the arteries, particularly the cerebral and the dural arteries, which are the pain sensitive organs inside the brain. Triptans also tend to decrease the sterile inflammation, which is also involved in the causation of the headache, and they do this by acting on the 5-hydroxytryptamine 1D receptors. So there are various types of triptans which are available. They are both long and short acting ones. The long acting ones are more effective during the aura phase, but they take a longer time to act. The short acting ones have more side effects. There are nasal preparations, oral medications, and mouth dissolving medications available. So if we look at the reasons to use triptans, then the first reason we have is they appear to be logical because they work on the basic mechanism of causation of migraine, and there appears to be a reason to prescribe them. So what are the options in various types of triptans? We have sumatriptan, which is available as nasal and oral preparations. It was available till now as a subcutaneous injection, but that has been withdrawn. We have elmotriptan, we have elatriptan, we have naratriptan, rizatriptan, which is available as an oral formulation and also as a mouth dissolving tablet. It was till recently available as a mouth dissolving cascade, but that has also been withdrawn. And we have zolmitriptan as nasal preparations. Now, this is a busy slide, but what it basically means that most of these triptans, regardless, have an onset of action not before 1 hour. Now, most of them actually start acting after about 2 hours of their intake, and also their half-life is variable, where you can see that it is the frovatriptan and naratriptan which have got a long half-life, and the other triptans have got a shorter half-life. So the medication rebound headache is likely to be the least with frovatriptan and naratriptan, but unfortunately these are the ones which are relatively milder and they do not have that type of an effect, as I will be telling you shortly. So when do you give the triptan? It is basic. So basically it is best to prescribe the migraine early at the onset of the headache. If you prescribe these triptans in the prodromal phase or in the aura, they are unlikely to be beneficial. As soon as the headache begins and the people feel that it is about to increase, that would probably be the best time to deliver your triptan. So the second reason for use is that it's a nice cafeteria. It's a great menu to look at. There are various ways and means to administer the drug. It can be given even during the phase of an attack, unlike other non-steroidal anti-inflammatory drugs which are to be taken in the prodromal phase. But it is important to understand, is this menu tasty, healthy and affordable? So that we will see according to the next presentation, that would be on the choice of triptans and also the efficacy trials and the analysis of those efficacy trials. So which one to choose? There is no class effect. Recurrent headache may indicate a need for repeat dose but not a new triptan. It would depend upon the pharmacokinetics and the side effect profile. So, what would help us in choosing the triptan is how quickly does it start to work, when does its maximum effect reach, what percentage of the headaches are gone, are there any side effects, and does the headache recur after 24 hours, and that would be revealed by the meta-analysis of the safety trial like this one, which was done by Ferrari et al. And was published in Lancet in 2001. The objective was to evaluate the available tryptans in terms of their efficacy over a period of time. And it was found that 87% of patients from so these are the various parameters on which this meta-analysis was basically conducted. So the first parameter was headache relief at 2 hours. So it was seen that rizatriptan and elmotriptan are the ones which performed best on this particular assessment parameter. Sumatriptan 100 milligrams was supposed to be better as compared to sumatriptan 50 milligrams, but the side effect profile was relatively inferior. If you look at the pain freedom, then it was rizatriptan and elmotriptan again which scored better as compared to others in terms of pain freedom at 2 hours. Sustained freedom from pain was again the best with rizatriptan and elmotriptan. Headache relief at 2 hours in at least 2 out of 3 attacks was also the best in rizatriptan and elmotriptan. And pain free at 2 hours again in 2 out of 3 individuals was also the best in rizatriptan and elmotriptan. So it was found that in a meta-analysis of these trials, it was probably that rizatriptan was the one which was best tolerated, had the best effect profile, had the best chances of creating a pain-free individual, and the maximum chances of causing freedom from pain after repeated administrations. And this was followed by elmotriptan. So it is actually a very large meta-analysis in which about more than 20,000 patients were evaluated as a group for various types of triptans in various studies. So which is the best triptan? The one that best works for you and your patient is probably the best, and all these triptans are actually more similar than different. So efficacy trials basically give us the third reason to use that these drugs are effective. But if you look at further deeper analysis, then efficacy is not actually as much as it has been projected. The duration and degree of effects remains questionable. Not all people will have a meaningful and a complete sustained relief from pain. And I feel personally that there are 2 types of patients. One, those that will respond to the triptans, and others who will be non-responders. So it might not be that these are the best medication for all patients. And then we have these other analyses which have evaluated these efficacy trials. So this was done by Edelman and Belsey in 2003. Now this basically gives you a completely different picture. So in the first trial, in which 50 milligrams of sumatriptan was evaluated in 602 patients, only 24% were headache free, and the number needed to treat was 5.4. So roughly 5 patients had to be treated for 1 patient to be headache free. For the 100 milligram trial, 1800 patients, 30% were pain free, number needed to treat 5. Rizatriptan to 1000 patients, 40% pain free, 3 is the number needed to treat. Zolmitriptan, 700 plus patients, 30% pain relief, 5 number to treat. Similarly, zolmitriptan 5 milligrams, naratriptan. So you see across, none of the triptans have been able to make a pain-free individuals in more than 35 to 40% of patients, and the number needed to treat is 5 to 8. So many patients have to be prescribed with a triptan before you find a meaningful relief in one individual. This is another systematic review in which various studies were reviewed, and it was found that sumatriptan, elmotriptan and rizatriptan were the best triptans as compared to others in terms of their efficacy profile. But this was a funded trial, and all these authors which actually evaluated these, they were on I'm sorry. They were funded by the pharmaceutical company which actually performed this meta-analysis. And then this was an evaluation done by Rappaport et al., which found that sumatriptan, zolmitriptan, elatriptan, rizatriptan, they were practically similar in their efficacy, but they found that sumatriptan 100 milligrams was more effective but had more side effects. So basically all the meta-analysis have shown that they are effective drugs, but their efficacy is not actually as much as it has been promoted. And then we also find that there is an extreme paucity of literature where triptans are compared with other medications. For example, there is only 9 published double-blinded studies in which oral triptan and a non-triptan has been evaluated for an acute treatment of migraine. 6 of these are with sumatriptan and other drugs. Zolmitriptan has 2 trials and elatriptan has 1 trial. And it was surprising to understand and see that statistically significant difference was not observed between triptans and other drugs in responsiveness during an attack of migraine. So this gives us the first reason for not taking. The efficacy trials show a high number needed to treat for pain relief. They have low rates of pain freedom. I would want my patient to be pain free rather than pain relieved. Pain recurrence is a distinct possibility, and there is not enough good quality trials to compare them with other oral acute medications. So, this I think I'll omit. Now, let us look at the side effect profile. So, what's happening? This is not the font which I had used anyway. So, so if you look at the side effect profile for, let's say, sumatriptan, then it causes change in taste, discomfort in the jaw or mouth, dizziness, drowsiness, lightheadedness. Now these are the usual side effects which are innocuous. The ones which are relatively serious ones, it can cause severe chest pain, it can cause convulsions, swelling of the eyelids, and shortness of breath, amounting to basically breathlessness. So if you look at these side effect profiles, none of them appear to be serious. But obviously, the ones which are the rare but the severe ones need to be taken into consideration. And if you look at the other triptans, then practically all of them have got the similar type of side effects like dizziness, nausea. But rare side effects, which are the serious ones, are almost similar. For example, a chest congestion, a compression feeling in the chest, pain in the chest, pain in the abdomen. So these are the usual side effects. And we should understand that patients who have a cerebrovascular accident, patients who have a coronary artery disease, patients in the extremes of age, particularly older individuals, these are the ones where triptans are not to be given. So basically the side effect profile of all these triptans is almost matching, except that the sumatriptan is probably the one, particularly in higher dosage, which has the maximum side effect potential as compared to other triptans. So these are the neutral aspects of triptans. The side effects are common, but most of these side effects are serious. They're non-disabling, and we need to know them apart from the indications as to where these triptans are contraindicated. Now let us look at the cost. All triptans are costly. One dose of the drug costs just about 50 to 70 rupees to go out of the pocket of your patient. And if you look at the number needed to treat, then effectively about 250 rupees would be spent for every headache relieved, and about 500 rupees would be spent for every headache treated. And there are again no comparative trials for the usual analgesics when they are compared against triptans. So I would like to conclude by saying that triptans are definitely not a new entry in the migraine management. They appear to be migraine specific in action, but I think their efficacy is overinflated. The side effects are acceptable, and there is no doubt that these are costly alternatives. They might have an important role in migraine management, but they have definitely not revolutionized it. And acceptability even at the level of neurologists is not very high. So I would end my presentation by asking, by telling that tryptans are one more new option in that cafeteria of acute medications for migraine. It's an effective option, but it might not be the most effective option in all patients. In those where it works, it does cause a big relief. But we should understand the restrictions for its usage and they should be honored. And medication overuse headache is a distinct possibility with tryptans, because even in the classification of medication overuse headache, the tryptans are required to be administered for less number of times to cause medication overuse headache as compared to non-steroidal anti-inflammatory drugs. So I would like to end my presentation with a question. How many of you use tryptan as the first acute medication in migraine attack?
I'll take it themselves.
That is okay. We're not asking personal questions. How many give it as a rescue medication? How many use it as a last resort before injectables are given? And how many never use it? Okay, so we find that most of the practitioners in India are reasonably comfortable with taking these medications, but they still feel that they might not be the first alternative. And most of them, and including me, would be using these as the first resort after their first usual acute medication has not worked. Thank you very much for your kind attention.
Thank you, Sumit. We are allowing questions because Sumit has finished 3 minutes before. So in that time, I allow the audience to ask questions to complete the management of acute migraine. Any comment?
Dr. Ravi, I invite comment.
Sumit, how would you see in the West when you attend meetings, ergotamine is not at all discussed nowadays. It's in fact called a dirty drug, but many of our patients cannot afford tryptans. So how would you position, given all the data that you have presented nicely, ergotamine still in vogue, not in vogue, and the second, along with that, the ergotamine usage. I have never come across a patient with ulcers following prolonged medication overuse headache with ergotamine for 15 years, 13 years. Why is it that this is a difference from the West, where you see book pictures of ulcers developing following ergotamine, and how many of you have seen ulcers and vascular complications with ergotamine in spite of such a prolonged overusage?
Sir, that is a question. I wanted your comment. But anyway, see, the point is, if you look at all these trials, then they give us a very rosy picture about tryptans. The actual analysis basically tells us that these drugs are costly alternatives to better available treatments or equally effective treatments. Ergot is never going to be compared with tryptan because I think the ergot is a very, very effective drug. The point is we are not used to prescribing it. I personally have not written an ergot preparation in last 10 years, not even one. Because we are probably more convinced or more influenced by those pictures than the actual reality. We all know that ergots are being taken by patients for relief of migraine. We all know that it is working very, very well. The only thing is that our comfort level with ergot has gone down. And nowhere in the world will a trial be conducted to compare an ergot with a tryptan. For that matter, comparing a naproxen and a domperidone combination versus a tryptan, because if the naproxen wins, then these medications would be out of job completely. It is just like methylprednisolone for AIDP versus IV immunoglobulin. That trial is never going to come in a big way. It is just like trial of azathioprine versus interferons in multiple sclerosis. It is never going to come. So I think that it is the economics which decides these trials more than actual efficacy.
nowadays, Dr. Sumit, the analgesic combined with triptan preparations are approved. And I think those patients who are not responding initially can be combined with analgesic preparations with sumatriptan, which is available.
Yeah, there is one trial.
Can
I'm coming to that. There is one trial in which this combination of sumatriptan, naproxen, and domperidone has been compared with sumatriptan alone and with non-steroidal anti-inflammatory drugs alone. So it was a 3-phase study in which it was found that a combination of triptan with the non-steroidal anti-inflammatory drug is definitely a superior option as compared to either of them given in isolation. But what I do is that I usually start with a non-steroidal drug, and I'll tell them that if you feel that this is a severe headache and your non-steroidal has not worked, then you can take a combination pill that would be probably working better.
Each the major.
This question, I have been using Ergot for the last 20 years. I am from a region where maybe 80% of my patients cannot afford tryptans. So I do give whenever affordable patients come. But I find it very useful. Maybe nearly 100 Ergots we give from the pharmacy every day. Other than the GI problem, and if you can avoid all those contraindicated hypertension, coronary, and spasm, etc., you have a very satisfactory result. And I have never thought of avoiding alcohol.
I have absolutely zero experience with it. So
Dr. Dameja.
I just want to direct one of the patient whom I had seen about 15 years ago. She was a case of migraine. At that time, CT scan was done, which was normal. And she has been on drug, and she never followed me all those 15 years. The only rescue which she had was on Ergot, that was a brain. When it was needed, she took it. This time, she again tried 1 tablet, 2 tablets, no relief. Then she came to me that I am not getting relief. When I said, where were you all these years? I said, you better get a scan. And unfortunately, there was a tumor in the patient.
Ergot preparation available in India. Ergot preparation available in India contain paracetamol and chlorpromazine and caffeine. Now, dose of paracetamol is low. It is 325 milligram. So what I do that most of my patients are poor, so I use Vasopril as the brand preparation and add naproxen acid. And I have got excellent results and I hardly use tryptan. I use tryptan only when these combinations fail. One thing is that if you start using it, take care of the fact that these tablets contain low amount of acetaminophen.
Thank you.
Another inhibition in using ergots is their tendency to cause medication overuse, and that has been really troublesome. I have had a large number of patients whom I have actually taken off ergots because they had developed medication overuse. The point is, our patients are not educated by clinicians to the extent that the rescue medication has to be taken only up to a particular limit. So what they tell you is that ye wali goli kha lena jaldi sar jayega. And then this ergot are very prone to cause that medication overuse headache. And I had a doctor from Kota, which we discussed in the last headache meeting. He was taking 4 vasograins, 3 triptans, 1 injection of pethidine and phenargan practically every day for the last 6 years. And he was in a mess. So that is one inhibition which I have in prescribing ergots. In India, usually triptans are not probably that common a cause of medication overuse headache as ergots are because of the costs involved.
Last comment.
I agree with you absolutely. I mean, and the problem with this, ergots is that in India the preparations which are available, they have lot many variations in terms of the amount, the content, the combinations. So actually you are not sure that what exactly you are giving and what the patient is actually buying from the shops. So there might be differences, and that might cause tendency for the medication overuse. And I think the triptan, the ergot problem with medication overuse is understated in India because we have not really looked into that in great detail. So by saying that ergots are very, very effective, because one thing, great advantage of ergots is this: they are irreversible blockers. In contrast to the triptans, which are temporary blockers. So you have a sustained effect for a pain-free period for a longer time. So that's a great advantage. But I think we have not really looked into total Indian scenario. We are talking from a personal experience, which is important, but that might not reflect the overall picture. And the triptans is, I think, even in India now, as Dr. Amachakwa is saying, India is booming. I think cost is not that much of an issue. The issue is there's a lot of mental block that triptans might be kind of doing a lot of harm to the patient. So that kind of thinking has been there in the physician's mind, even in neurologist's mind. And I was surprised to see Dr. Vivek Lalute in a headache meeting. He blatantly said that I don't use triptans because the first two patients I gave had coronary symptoms and went to the ICU. I think that those statements are exaggeration, and that gives a bad message kind of a thing. It's a useful drug. It's a useful drug. You have a choice. If the patient cannot afford, don't use it. But if the patient can afford, and if there are situations when you can use it, you can use it. That is my position.
Thank you, Dr. Sumit.
Thank you, sir.
And I will always say that no two patients of migraine, acute attack, are going to be same. Your treatment is going to be a combination of drugs or a single drug which relieves all symptoms of patients. Like many patients may have anxiety, nausea and headache in various combinations. So most of the time, I think we are not using one drug. This is number one. Number two is, whenever we are saying that we don't have enough evidence or we don't have promotion of drugs which are more cost effective, I think that's why we are here, and we can find out which drugs are better for our population